Okay, thank you. Yeah, good morning. You probably remember me from yesterday. I remember you. Angelman syndrome. Well, why speak about Angelman syndrome? Angelman syndrome is a very rare condition. But if you take all the rare conditions, there are many of them. And so many children who we know will have a rare condition. The idea is not to know all of them and all about them. But I want to present this as a case example. How far we can go. So it all started, the reason why it's called Angelman syndrome is because it was reported by Dr. Angelman. Dr. Angelman was a pediatrician. He worked in the United Kingdom. And he saw 3 children. And these 3 children were not from the same family. They all presented with severe developmental delay. They all had seizures, and they had a funny behavior. And he thought, well, maybe that behavior is a clinical clue to what they have. And maybe, because they share those features, they have the same condition, which had not been described. So what did he do? He described them together. He called them puppet children, because the way they moved made them think of puppets. So he said they move like that. And they smile a lot. And he submitted it to a journal, for which I'm now the editor. So very impressive to think that Harry Angelman could have submitted his paper to me, and I would have said, well, there's something there. Let's show it. Let's share it with the community. And this is exactly how it worked. So a few years later, other people saw it and said, well, and we've seen 2 children, we've seen 7 children, and we went on. So why did he thought of calling them puppets, and why did he thought of describing them together? He loved art, like many people in this room, I see. And when he was on holiday in Italy, he saw this picture, and that's a child holding a picture of a puppet. And that child was smiling, and he said, well, that's it. These will be puppet children. After some time, in 1995, and then a revision in 2006, people around the world who'd seen many children and less adults with Angelman syndrome got together and said, well, let's suggest diagnostic criteria. Very interesting, because by then, a causative gene was known, but they still said primarily a diagnosis is a clinical diagnosis. So they said all the people we know have a developmental delay. All of them have a movement disorder with ataxia and with jerky movements, a funny way of walking, and all of them, and that is a clinical sign, have a behavioral phenotype which is quite unique with what they call apidemia. They're very excitable and they move all the time. They're very friendly to people with Angelman syndrome, and the laughter is really to the forefront. And also, all of them have this very severe speech impairment. Most of them have no words at all, and those who have words, even those who have a record number of words, I mean more than 5, I mean even 20 words, would not use words as their main means of communication. And this contrasts with receptive language, and it contrasts to some extent also to other ways of expressing yourself. Seizures is really to the forefront, more than 90%. And there is an EEG we briefly discussed yesterday, which I think is, if not pathognomonic, which is too difficult a word, is very, very evocative of Angelman syndrome, and it's certainly an early feature. And other things, like they love water. So if you go by a lake, by a swimming pool, they'll be in the swimming pool in no time at all. Now, I had problems with the Walt Disney Company, but then they forgave me by suggesting not so much that Dopey in Snow White and the Seven Dwarfs had Angelman syndrome, and actually the character was not based on someone with a disability, but could be used for didactic reasons, because it's easier to remember. Use no words but signs, understand speech, has problems with coordinations, and he even has a seizure while sleeping. So if you want to watch it again, smiles all the time. And indeed, he gets into the water when he's supposed to be washing his hands. So I said the Walt Disney Company wasn't too happy, but then they let me, and then because it was such a long time ago and it was so impulsive, I wrote it up, and it's in the literature. And then it was in a BBC program, but I wouldn't do that again. You know, I started writing about Popeye and Henry Dreyfuss muscular dystrophy. I stopped. So of course, Popeye is not strong; he's weak, and he's not all that weak when he has spinach. And the spinach is not the iron, because we know that's a mistake. So I started thinking about folate, but I stopped there. We'll get some folate here. You may know Angelman syndrome. Because of this phenomenon. It is a good illustration of genomic imprinting. So imprinting, genomic imprinting, that is what we can do to genes. And when we talk about imprinting, genomic imprinting, when there's a difference in gene expression on whether the gene, the same copy of the gene, is inherited from the father or from the mother. Nothing to do with sexual chromosomes. So we each have a pair of each of the chromosomes, and this is chromosome 15, and we inherit one chromosome 15 from the mother, one from the father. Now, if you miss a bit, if there's a deletion, as we had the explanation yesterday, on the maternal part, in this region, you will develop Angelman syndrome. And if you have a deletion in exactly the same region, but on the chromosome you inherited from dad, you would have a completely different syndrome, Prader-Willi syndrome. Now, most cases, as we heard yesterday, are due to a deletion. That is, there's a chunk of the chromosome that is missing. It's an accident. And that has been known since the 1980s, since 1987. But then, in 1997, 10 years later, the causative gene was identified. And that's the UBE3A gene. Now, in that region, there are other genes, like a number of genes encoding subunits for the GABA-A receptor. Also, this for tyrosinase, hydroxylase, so that has to do with pigmentation, and also other genes. The cause of Angelman syndrome can be found in 80% of the cases. Why is that? We know the genetics of it, because Angelman syndrome is still defined by the clinical presentation. And this is why, within the context of this clinical presentation, you will find a genetic cause in 80%, which is good, but it's not 100%. And in all of these, you would have reduced expression of that gene. Now, I asked a daddy of a boy with Angelman syndrome who draws books for children to help me explain this. So I suggested a metaphor and asked him if he could do this. And so this is how it works. This is the chromosome inherited from the father and the one from the mother. And in the typical situation, all of us and all the people, we only read the gene, the copy on the gene, on the chromosome we got from the mother, and not from the father, because we have an epigenetic mark saying, don't read it. In most cases, you have a deletion. That means there's a problem, there's a bit missing. Now there may be a mutation, that is this one very small part of the gene that's mutated. So you end up with not being able to read the UB3A gene from the mother, and from the maternal chromosome, and we know you can't read it from the father's chromosome. This is the vast majority of cases. Now, in very, very rare cases, you may have a problem with the epigenetic mark, and you don't identify the chromosome as being from the mother. This is the methylation problem that we heard yesterday about. And then, even more uncommonly, you do not have two copies of the chromosome 15, one from the father, one from the mother, but two from the father. It's very rare. Anything can happen, even this. For example, you started off with only one chromosome 15, and that's not good. So as a compensation, you copied it twice, and you find yourself with two identical copies. Or you found yourself with a trisomy, but chromosome 15 is much bigger than chromosome 21, so you can't live with three. So you kick one of the three out. And if you happen to kick the one you inherited from the mother, you get two different ones from a father. Now, this is the title, An Inspiring Molecular, Physiological and Clinical Symphony, even though we need to start with the clinical aspect. And I'll just take a few aspects. There are many, many aspects in Angelman syndrome, like in any syndrome really. But the behavioral phenotype is to the forefront. It's very important. That this happy demeanor and something that I like to call exuberance. These children are really exuberant. Now, there has been long-lasting debate about laughter. Is it inappropriate? I think it's very difficult to judge. My personal view is that people with Angelman syndrome have an excellent sense of humor, which we don't share. But laughter can also be an expression of anxiety. So you would see someone with Angelman syndrome laughing when it's clearly an unpleasant situation, a blood test, another situation in which you wouldn't laugh. But that doesn't make the laughter inappropriate, and there's been good research about it. For a long time, people have said, well, this is autism. And in autism research, in genes, in many genes implicated in the autism spectrum disorder, the UBE3A gene is often cited for good reasons. But most people with Angelman syndrome do not have autism. And to say it more simply, there's no autism in Angelman syndrome. This is questioned, and it all depends on how you make the diagnosis. So you could say, they have ADHD, they have an attention deficit, and they're hyperactive. I do think it's helpful to say that. And I'm not happy saying that there's ADHD within Angelman syndrome. I think there's Angelman syndrome in Angelman syndrome. And in press now, I just saw yesterday, there's this discussion. Do individuals with Angelman syndrome have maladaptive behavior? And a discussion. And the answer is, well, it's not easy, and you would not say yes, says this Danish colleague in reply to this interesting paper. Discuss possible biomedical and psychological triggers of maladaptive behavior to identify effective behavioral and pharmacological treatments. And this is a good lesson for anyone. Do not treat it as syndrome. Try to understand the mechanism. If a child is aggressive, what does it mean? Especially a child who can't speak, who can't express themselves in normal ways. This photo, by the way, is an attempt, failed attempt, to get a photo for the child's passport. But it just is a measure on how hyperactive they can be. Cognition, very quickly. IQ is very low. Of course, there are problems with using scales for people with a verbal impairment, with a motor impairment, and with attentional problem, possibly with motivational problems. But functionally, intelligence is limited. But let's keep in mind that past adolescence, or from adolescence, when hyperactivity diminishes, maybe people with Angelman syndrome are more open to learning. This has great implications in the way we organize education for people in need for special education. Just what perception, like in anything, and we had a very good presentation yesterday, which was more general, and there are specific things, or more specific things for Angelman syndrome, but just here, if we look at the ophthalmological problems, we notice that there may be there are some specific reasons due to the deletion and some gene expression and pale fundi and so on, yes? And you can't do much about it. But there are also very simple visual problems, and I see that a few of us in the room have glasses. How many people with developmental disabilities are in need for glasses and we never think about it? And we say, well, it's just limited, so why wouldn't we? Then you can say, well, but they wouldn't accept them. But often we don't even think that. So don't forget to think about the possible need for visual correction in people with disabilities. Communication, okay, non-verbal communication, and that's a very interesting topic in research, and therefore alternative ways for communication, and that changes people's life. And there are many, many possibilities that are constrained by intellectual problems, motivation problems, and so on. But there's something in Angelman syndrome which there isn't in autism, this eagerness to communicate. Sleep, big sleep problem, like in many neurodevelopmental problems. So people used to say that there's a reduced need for sleep in Angelman syndrome. And once an author wrote it, all the other authors in subsequent papers would say, and there's a reduced need for sleep in Angelman syndrome for years and years and years. What does it mean? I mean, I hardly sleep. I would love to sleep, but I have a sleep issue. But it's not that I don't sleep because I don't need sleep. I'm sure I'd be better if I could sleep. And so there are sleep problems, and some children with Angelman syndrome during childhood sleep a total of 3 or 4 hours in 24 hours, which is a big problem, including in families. But I'm not sure that means that there's a reduced need. We don't know exactly what a relationship bilateral, reciprocal between sleep and epilepsy, between sleep and learning. Motor control, this is my passion, and this is why I'm trying to avoid it now, not to take too much time. But this is so typical, this way of walking is typical. There are good reasons, and so this is in our patients that lend themselves to my games some time ago, and more things. This, which we don't understand. In young adults, you can see this very disabling tremor It can last for days. And some people have said, well, this is typical Parkinson's. Well, it isn't. But they tried levodopa, and in 2 patients or a few patients it worked. Other people said, well, it's cortical myoclonus, and we tried that, and therefore give piracetam at the time. I don't know what it is. The EEG, just one illustration. So this is pattern 1A, and we described 3 patterns, 1A, 1B, and then pattern 2, pattern 3. They're very interesting, they're very useful, and this is not status epilepticus. This is dramatic, and if you've never seen it, you say, what's going on here? This is epileptic in nature. Well, it isn't. That pattern isn't. There is epilepsy, and there's even non-convulsive status epilepticus, which is more common in Angelman syndrome than in many other conditions. And when parents say, well, he's not his usual self, and the behavior fluctuates, and he's being slow, and so on and so on, for days and weeks, even months, that could be status epilepticus. The question is what you do with it, and my answer for children is you try to treat. And then with humility, and if it doesn't work, just let go. But not like in adults where they say, well, it doesn't matter. Why? Because children learn. Children still need very much their experiences. It is very relevant to brain development, but that's a debate. So, what do we know? We know a lot. How can we apply it? Well, therapy. So you remember what I showed, and I asked them, well, could we do this? So, we can't use UB3A gene from the mother's chromosome. Could we unsilence the chromosome inherited from the father? That would be good. Now, a few years ago, I went to Ireland, and I saw this girl, and I couldn't understand how they got this picture. They have a very good camera that can take a photo in a split second, because she was all over the place. But there on the photograph, she's sitting very nicely, and I didn't like the message. She's not saying it, they pretend she's saying it. Scientists have reverse Angelman syndrome in a mouse. Now it's my turn. Nice. A lot of hope, but sadly, this is not yet how it works. So there's a lot from a mouse in the laboratory to children on the playground. The thing is that gene and that region has an equivalent in animal models, and that is very good for understanding. That gene, the UB3A, is expressed in animals and in people, not everywhere. It is expressed in a mouse, for example. It is expressed more in the cerebellum and in the hippocampus. But if you don't have a maternal copy here, this is a mouse model to Angelman syndrome, it is not that you have no expression at all. You have no expression of UB3A at all in a mouse if you have no copy, neither on the father's side or on the mother's side, meaning that there's some minimal expression here, and this gives great hopes. Many animal models, and there is a fruit fly homologue of the gene, and if you destruct it, you can see things in the nervous system, but you can also see things in the wings. I wouldn't go as far as the authors and characterizing as ataxia the way those poor fruit flies try to fly. And we need to really be careful and not want to extract more from animal models than what they can give us. But here in the mechanism, they can give us a lot, and we understand some of the functions of the UB3A gene. We know what it is. It's a ubiquitin ligase type 3, and that means that they're active in a system where we tag proteins. So we add bits of ubiquitin on a protein. So there's a protein complex that does that. And why do we tag them? Usually for destruction. So unfolded misfolded proteins, old proteins, that is, we get rid of them by saying, well, this is not good, go for recycling. And so we recycle them. But there may be other functions to this tagging, to this marking of protein, for trafficking, for moving inside the cell. And one other example here is expression, so moving GABA A receptors that are complete with all their subunits. So, well, I suggested a hypothesis a while ago that literature is not linear, so sometimes people study it and sometimes they completely forget it. I don't know. I had fun thinking about it. I don't know if it's true. I'll explain it to you if you're interested. We don't know what is relevant in UB3A. So we know that it ubiquitinates proteins, loads of them, including itself. But we don't know which of the targets are really important. But we know, for example, that it plays a role in maintaining active dendritic spines. So, as it were, we start with few points of contacts on our neurons, on our dendrites, and then we make many, non-specifically. And then we begin to select those that we use not too much and not too little, and those are relevant. And if you have a problem with UB3A, you find yourself with less contacts, and that might link to the learning impairment, and perhaps to the seizures, and perhaps to ataxia, and all the other manifestations. I think this is rather interesting. Animal models, you can study them in a way you can't study people, and this is a work that we've been busy with. Tiny electrodes inserted in the cerebellum of mice, and trying to understand how things can be changed. Also, try medication. It's very complex. We're finding things, but we don't know how relevant it is. You can try reversing, so rescuing functions, and see that mice perform better on tests. And then you can try things in humans. Sometimes even, I don't think it's really ethical, without having tried them in animal models first. And so this methylation thing, people thought, well, we know that the methylation, these epigenetic marks of the DNA are influenced in part by how much folate, folic acid and betaine you have. Shall we give that to children? And people in 2000, started in 2000 until 2003, did a trial, and it didn't work. Now, the conclusion was, maybe we didn't identify the right patients. Yeah, maybe, and maybe it doesn't work. A few years ago, there was this trial. You may have heard about it if you were on Facebook, because they were recruiting patients on Facebook. I think this was an ethical trial. I said it, so I was a reviewer for this paper 4 times, and I said reject for my reasons, and the 4th time it was eventually published. But this was based on the assumption that minocycline changes epigenetic marks, and it has been used to that effect in schizophrenia studies. The way the study was constructed was not good. And as I explained yesterday when we talked about ethics, you need to be even more prudent in children. This is great. So, this is empirical. So, how I came to know about it. Nature, the journal, or the magazine, contacted me saying we embargoed a paper. It was going to be accepted, we were going to publish, but we would like your opinion, because some people now, and on last reading, say it is not scientific because there's no hypothesis. So what these people did, they took mice and they looked at UB3A gene expression after submitting those mice to all the drugs, the 2,000 and so drugs approved by the FDA, by the Federal Drug Agency in the United States, to see if there would be a difference. And they found one family of drugs, of anti-cancer drugs, and within that family, that drug that unsilenced the expression of UB3A. And they said, well, and we know that it's because that drug breaks the DNA. And when there's a repair mechanism, that mark got lost. This is a great hope, but it does not mean that this anti-cancer drug that breaks the DNA and is very useful in certain forms of cancer is a valid treatment in Angelman syndrome. But you see, there's this big hope. Other things have been tried and don't really work well, including something now. An editorial I wrote some time ago, Pure Neurodevelopmental Genetic Disorders, Please, and I say that we need to resist the tyranny of the idea of a cure when it is not possible. Perhaps it is possible. Perhaps I'm just, too rigid in my mind. I accept that. But we don't have anything now. So the priority now is to keep the priority, and that is looking directly after the child, and in particular function. So previously, and I was trained like that, we focused on impairment. We wanted to treat, that was the role of a doctor, and when possible to cure. And we said, well, if we treat, that will improve function, if there was a question about function. And we wanted to make activities normal. We wanted to normalize children, and we wanted to prevent abnormal ways. And we knew that great intentions are great. So if we do our best, as I said yesterday, that's the best we can do. But now we know that it is not true, it is not valid. It does not work. If we really want to talk about function, we need to look at function, to look at what people do. We need to focus indeed on activities, but the way they do them, and on participation, and we need to set goals for management. We need to measure where we are, and this will improve function. It's not specific to Angelman syndrome. We need to still be in the present and be busy with a vision, and also being proactive towards the future. Quality of life, participation. We need to identify and make priorities within health issues. We still need, all of us, to have a holistic management, and also provide specific treatments. And we need to listen to the news continuously in a critical way, because there's currently a boom in new treatments, and it will bring our practices to new dimensions that is hard for us to anticipate. Thank you.